CNS, I think we need to cover this under, I think, 2 or 3 parts, because there are many important infections in the central nervous system, which are both important for the clinical purpose and for the entrance purposes. The questions do appear in the NEET and AIMS and all these kind of exams regarding these section, that is central nervous system infections. Sometimes they appear very easy questions because they share a lot of information with other subjects also. But some things I will like to discuss is the clinical aspect here. So we will straight away start the discussion with the first case here. Here is a 32-year-old woman who had an upper respiratory tract infection for a few days. Then she complained of severe headache and became confused, and starting talking about the strange odors and seeing snakes in her bedroom. So lumbar puncture revealed clear CSF containing 53 WBCs per millimeter cube, predominantly mononuclear cells. The glucose protein were within the normal limits. Which of the following type or location of the lesions are most likely? So they're not asking the diagnosis here, they are asking the pathology here. So the first option is the oligodendrocyte necrosis in subcortical white matter, the fibrosis in the cerebral cortex, the neuronal necrosis and perivascular coughing in temporal lobes, and purulent exudates in the subarachnoid space. So if you see the case actually here, this is a middle-age woman who, after and having upper respiratory tract infection, developed some CNS symptoms, that is headache, and then she became confused and started talking about the strange odors and seeing snakes in her bedroom. There is nothing but a hallucination, so it is a part of psychosis, which usually develops in case of the encephalitis, including the temporal lobes, where the visual hallucinations are very common. So, and the lumbar puncture revealed clear CSF. That means the CSF was not cloudy or it was not pus kind of thing. It was some amount of pleocytosis was there, which was predominantly of the mononuclear cells, and glucose protein were normal limits. So this amount of CSF pleocytosis is very common in case of viral encephalitis. So this is not a case of meningitis or a bacterial meningitis, because the glucose and proteins are normal and the cells are predominantly mononuclear. So since it is not a case of meningitis, the purulent exudates, the subarachnoid space is ruled out because it is a feature of an acute bacterial meningitis. And the remaining 3 options are the oligodendrocyte necrosis in the subcortical white matter, fibrosis in the cerebral cortex, and the neuronal necrosis and perivascular coughing in temporal lobes. So as we see, the features are suggestive of visual hallucinations here. The temporal lobe becomes the location. So you can choose the option based on the anatomical area in this particular question. And the other very important feature of this viral encephalitis is the neuronal necrosis and the perivascular coughing, which is seen in all kind of viral encephalitis, which is not specific of only herpes, but it has been a feature of any virus which causes encephalitis. Whereas fibrosis in the cerebral cortex is a feature of the abscess or any chronic inflammation. So if you see any chronic thing is there, then the fibrosis is the thing. And oligodendrocyte necrosis in subcortical white matter is usually a feature of demyelination, which is seen in some multiple sclerosis or post-infective encephalomyelitis, all these kind of things. So here the option and the right answer is the neuronal necrosis and perivascular coughing. So these kind of questions do appear in the exam, where you don't actually study the questions directly in the textbooks. So the pertinent knowledge regarding the subject is very important to solve the questions, and the way you see that particular question also matters a lot, because this question, you know, I'm discussing the CNS infection, so you'll be thinking only about CNS infection, but in the exam, when you're solving 300 questions at one particular time, so you will be having a lot of things going inside in your mind. You need to have a very clear mind and keep it as simple as possible when you solve the entrance questions during the exam time. Don't make things complicated. Always try to keep things simple. Again, to take an example here, there is a 78-year-old man who was taken to the hospital with fever and headache 1 to 2 days duration. That is an acute illness. The examination revealed the nuchal rigidity, the confusion, and a temperature of 102 Fahrenheit. The lumbar puncture revealed the cloudy CSF, and the cells were very high, that is 6,000 WBCs. The glucose was low and protein was very high. So which of the following is most likely the organism involved? So if you study the clinical scenario here, this is a case of an acute bacterial meningitis in a very old age man, that is 72, 78-year-old man. So options given are the rickettsia, the streptococcal pneumoniae, the Mycobacterium tuberculosis, and herpes simplex. So since it is a case of an acute bacterial infection, Mycobacterium tuberculosis is ruled out because tuberculosis usually causes the chronic meningitis or subacute kind of meningitis. And even though Mycobacterium tuberculosis can present in a way which is similar to the acute or subacute meningitis, but the CSF picture here is not suggestive of tubercular meningitis, where the glucose is usually not low. And the herpes simplex one is a viral encephalitis, meningoencephalitis, the most common organism causing encephalitis in the real world. Again, the CSF picture is not suggestive of the herpes simplex here. And the rickettsia usually does not cause isolated meningitis in a patient. It is usually a matter of multi-organ dysfunction in case of rickettsia. So please read the question. The question is asking which of the following is the most likely organism involved. So even nowadays, the streptococcal pneumoniae is the most common organism causing an acute bacterial meningitis in any age group, in any patient. Even if they ask HIV, even if they ask anything, the most common organism, irrespective of the predisposition, the organism is the streptococcal pneumoniae. Although we have got some variations here and there. For example, if patient have some foreign body, the organism of preference may be different. But if at all they are asking just the most likely organism causing acute bacterial meningitis, it is streptococcal pneumoniae by all means. Please remember this answer. So on the back, even the question, sometimes the trick by giving an HIV as an example. For example, there is a very famous question in NEET, which keeps on appearing, I think, every 3 yearly or 2 yearly. What is the most common bacteria causing pneumonia in HIV? Everybody tends to go for the organism like Pneumocystis jirovecii, all these things. This is not a case. Even in case of HIV, most common organism causing the pneumonia is streptococcal pneumoniae. And similarly, in meningitis, the most common organism causing meningitis is streptococcal pneumoniae. Then, see, bacterial meningitis is actually a medical emergency, which has got a very high mortality if you actually don't treat the issue properly here. Although the real world incidence has been reduced drastically nowadays, the incidence of viral related meningitis has increased. The bacterial meningitis has decreased because mainly at the advent of vaccination. Because if you see, the most common organism causing the meningitis are the pneumococci and the meningococci. Now, 90% of the burden of the meningitis is being carried by these two organisms, and we have got a good vaccines and also the good coverage against these vaccines, so which has got the reduction in the incidence of acute bacterial meningitis very rampantly. It's been a while I have seen a case of bacterial meningitis which presented to us with the typical manifestations, which has become very rare nowadays, but it is very common also in some parts of the world, like in the developing countries and the industrialized countries. And the resistance of the organism to the antibiotics is being actively growing. For example, the pneumococcal resistance to the penicillin group of antibiotics is being growing rapidly. I think it has been almost doubled in the last 10 years. It was, I think, 10% in the year of 2008 or 9. And now it has come up to 45% resistance to the penicillin, and among that 20% are resistant to the third generation cephalosporin also. So we might see the pneumococcus, which is resistant to all kinds of penicillin groups, like even the cephalosporin resistance might develop in the future 10 to 12 years, where the treatment regimen, the empirical regimen to the bacterial meningitis may completely change. So the way we diagnose the bacterial meningitis and the way we treat is become a very, very important thing to further reduce the development of resistance to these organisms. So there are many organisms causing the bacterial meningitis. You need to have a little bit of microbiology knowledge for the organisms, so they can be either gram positive or they can be gram negative. Instead of asking direct questions nowadays, they are asking image-based questions. Sometimes they have a habit of giving gram-stained specimen to identify the organism, where it might seem look difficult for you to identify the organism. So gram-positive, they are violet. Gram-negative, they are pink. So next, gram-positive can be either cocci, gram-positive can be either bacilli. Then gram-negative can be either cocci, gram-negative can be bacilli. So if you see a violet organism in the gram stain, and if it is a cocci, that means it is a round shape, then it is usually pneumococcus. This has become a very unique way of giving examination questions here. Like they give a typical history of either a neonate or old age people, where they usually present to you with a feature of an acute bacterial meningitis, and they give a picture of CSF which is suggestive of acute bacterial meningitis, and they give an example of gram-positive bacilli was detected in the CSF, and they also give a picture where there are violet organisms which are there as rods. So the most common gram-positive bacilli which causes the meningitis is the Listeria. Although in India, the Listeria monocytogenes incidence has been low, it is not so much common, but it has been expected in our very old age people and very young people, that is very extremes of ages, are particularly prone for this particular organism, including the pregnancy. So we need to know this gram-positive bacilli, and because the treatment also differs, this needs to be considered for the addition of an ampicillin during our empirical management. So this becomes very, very important here. I think 2 or 3 times this question has been asked. They gave a picture of an acute bacterial meningitis, and they gave the gram-positive bacilli as the clue. So the gram-positive bacilli, I think the only important gram-positive bacilli which can cause the acute bacterial meningitis is the Listeria monocytogenes. And if you come to the gram-negative organisms, which are usually appear pink on the gram stain, so this has become, these are much less common compared to the gram-positive organisms. And among gram-negative, the gram-negative cocci are the most common organisms. That is, Listeria meningitis is a very common organism. The second most common organism causing the bacterial meningitis overall, and the most common gram-negative cocci causing the meningitis. So they have a habit of tricking you by asking questions like this also. What is the most common gram-negative cocci causing bacterial meningitis? So the option can be the streptococcal pneumonia. Since streptococcal pneumonia is the gram-positive organism, the gram-negative organism or gram-negative cocci which can cause the bacterial meningitis is the Neisseria meningitis. So these are the simple issues which you need to focus when you are giving during the exam, because as I told you, to have a clear mind is very, very important during the time of solving questions. And again, gram-negative bacilli, we know the very, very important in causing bacterial meningitis are the E. coli, the Klebsiella pneumoniae, and sometimes Pseudomonas and the Haemophilus influenza type B. So these are some important organisms which can cause the bacterial meningitis. So if you see the organisms, important features here, the streptococcal pneumonia is the most common organism which can cause the meningitis, as I told you, in all kinds of people. There is particular predisposition in some kinds of people because this has been situated in the nasopharynx. There is a direct extension across the skull through the cribriform plate. So if there is skull base fracture, the contagious spread becomes very, very important and very, very common. And any ENT disorder, like if they give a history of any ENT surgery or ENT disease being there in the patient, like if the patient has got the fracture of the cribriform plate, CSF rhinorrhea is there, potorrhea is there, cochlear implant has been done in the patient, and some amount of defect is there in the ear ossicle, that is called a Mondini's defect. So these kind of clues they try to give in the exam, which should take the organism towards the streptococcal pneumonia. And if you see the Neisseria meningitis, there is no particular predisposition except some rare complement deficiency. That is, even inhibitor deficiency are very, very common, and they are also very prone to develop this Waterhouse-Friderichsen syndrome of adrenal insufficiency in these patients. Whereas apart from this, there is no particular risk for this Neisseria meningitis, although when there is an outbreak of this organism, the close contacts become the risk population for the organism. And again, the Listeria monocytogenes, the older adults and the neonates, that is the extremes of the ages. And since the placenta is the site of the entry, pregnancy can be the risk in acquiring Listeria monocytogenes related bacterial meningitis, and some amount of defected cell-mediated immunity, like if the patient is on chronic steroid therapy or the patient has undergone some transplantation, especially the kidney transplantation, and the liver disease, malignancy, and the pregnancy, as I told you, makes the organism release cytogenesis. And any foreign body, especially the drains, like neurosurgery drains have been put on the patient, like ventriculoperitoneal shunts are there. So since the skin has been pierced and the skin is constantly disturbed in these patients, the coagulus negative staphylococci, these are the natural inhabitants of the human skin, can become the very, very common organisms causing the shunt-related infections. And again, the Staphylococcus aureus, when the patient has the Staph aureus endocarditis, some foreign body, again in the patient of ventricular drains, and the patient is having a cellulitis and a decubitus ulcer elsewhere, through the hematogenous spread, if the patient is immunosuppressed, can develop the Staphylococcus aureus. But overall, the community-acquired bacterial meningitis, Staph aureus, is a very rare cause. And again, the Haemophilus influenzae in the patient of diminished humoral immunity can cause the meningitis. One very important question that has been asked is the disseminated strongyl lordosis is a risk factor for the acute bacterial meningitis developed by which organism? And it is the gram-negative bacilli. Gram-negative bacilli, they are the major inhabitants of our gastrointestinal tract. The E. coli being a very common organism tends to acquire in the body of the strongyloid organism. And in the case of disseminated strongyl lordosis, are also called as an hyperinfection syndrome. So since the strongyloids larvae spreads all over the body, the E. coli can go into the CNS, can cause meningitis. And the clinical presentation again is very, very important, and everybody of us know there is a classic clinical presentation in the bacterial meningitis, that is a fever, headache, and meningismus, that is means the neck stiffness. The terminology given for the neck stiffness in the recent era is the meningismus. Although any of the combination of these three symptoms can be there in the patient, all three together can be very rare. They have given a fixed triad for the meningitis, that is a fever, the nuchal rigidity, and the altered mental status. All three symptoms together is very rare to see. That is, the less than half of the patients might have all three features. Whereas the patient can present with the fever, headache only, or sometimes in immunocompromised patients, fever may not be there also, especially in a very old age patient. Then this meningismus sometimes may be subtle, and meningismus, that is neck stiffness, is very severe. Patient itself comes to you with a complaint of neck stiffness. There's a stiffness in bending the knee, even though this is very, very, very important when headache is not there. Many patients can present to you just with a feature of fever and the neck stiffness without any headache, altered sensorium, photophobia may not be there. You need to suspect the meningitis in these patients, because the physician should have a very low threshold in identifying the risk patient, because this particular disease has got a very high mortality if it is not considered in the early treatment. So that's why the threshold should be very low. And the sensitivity of the tests which are there to detect the neck stiffness has been very, very low. We know that sensitivity detects the ability to rule out the disease. Since the sensitivity is very low, these actual signs are not good in ruling out the diseases. Like, for example, if the Kernick sign is negative, since sensitivity is very low, if Kernick sign is negative, then we are not sure whether it is actually meningitis there or not. It can still be meningitis as the sensitivity is very low, but specificity is very high. That means the ruling in is very high with the Kernick sign. Like if Kernick sign is there, then it can definitely be the meningitis. Whereas if the Kernick sign is not there, then the ruling out this is becomes very, very important. That's why we should have a low threshold for these identifying acute bacterial meningitis. So all the signs, the Kernick sign, the Brudzinski sign, all these have got a very low sensitivity. And among these meningeal signs, the neck rigidity was the sign which has got pretty good nuchal rigidity, which has got pretty good sensitivity. The specificity of both Kernick sign and Brudzinski sign is high. So the Kernick sign and Brudzinski sign, everybody of you might have already studied in the clinical things. So Kernick sign is also called as Kernick-Lassig sign. So it is actually Lassig who discovered this first, but the Lassig name is rarely used. The Kernick sign is used in the patient is supine. In all the textbooks, the position of the patient to test Kernick sign is being given as a supine position, but it can be done in a sitting position. The original article which published by the Professor Kernick and Professor Lasik, both independently published, both one in French and one in German, I think. So they both published this article individually and in the sitting position. So it is the supine position was later adapted for the diagnosis because sometimes it was difficult in case of the neonates and the altered sensorium patients. But this can be done in a sitting position. So in a supine position, the description is being available in all textbooks. The patient is being the knee is being made passively flexed to the 90 degrees with hip being flexed to 90 degrees. And the further extension of the knee becomes very, very painful. And the angle which give a pain is 135 degree at least. So the angle was also published in the the oldest article, that is 135 degree. Although anything above 90 degree should become painful. The lesser the angle, the more the pain or the more severe the meningitis or more the exudates in the subarachnoid space. That is what it detects. But if the 135 degree angle is not eliciting any pain, then it does not have any significance in the patient. Again, Brudzinski sign. There is Brudzinski neck sign, there is Brudzinski cheek sign. You need to go and read the textbooks. So this is actually the passive flexion of the knee makes the hip and knee flexed spontaneously. So this is nothing also but a neck stiffness due to the basal exudates present in the nerve roots due to stretching. There is one other signs of the meningitis also which are described in the literature. So this is what is called the Amos sign. When you ask the patient to get up from the bed, the patient takes the support of the whole body kept on the one limb backside on the bed. So this is called Amos sign. And when the patient actually sits up, takes the position of the tripod, which is also called tripod sign. Where the patient, since patient cannot extend the knee due to the basal exudates, he takes the support of the limbs on the bed to keep the knee in erect position. So keep the neck in erect position with the legs being flexed. So this is a very, very important sign. So these are the other signs of the meningitis which you should know, where some examiners might ask during the discussion. There is another very, very important sign, that is the jolt accentuation test. I don't know whether you might have read this sign or not. This is nothing but the horizontal rotation of the patient's head. So this can be done passively, or you can directly ask the patient to rotate the head sideways with a frequency of 2 to 3 rotations per second. So if you ask, or if you do a rapid sideway rotation of the head, whatever the headache of the patient is there, that gets accentuated. This is a very, very important recent sign of the meningitis. Why this is important? Because this particular sign was shown to have a sensitivity of 100%. That is why this becomes important to discuss here. So sensitivity, again, see, whenever you study some test, you need to know the sensitivity and specificity of the test, because whatever the test which has got a very high sensitivity, that means it is very good in ruling out the disease. And whatever the test which has got very high specificity, which is very good in ruling in the disease. So the mnemonic which I remember is the snout. Its sensitivity is important in ruling out the disease, and specificity is ruling in the disease, that is spin. So if you can remember this, this is well and good. So the jolt accentuation test for the meningitis has got 100% sensitivity. That means if the jolt accentuation test is not there, I mean, if it is negative, then it is very unlikely to be a meningitis. The meningismus is very rare if the patient does not have any jolt accentuation test. That's what the sensitivity means. So now we have got a very good test which has got a very high specificity, that is Kernick sign and Brudzinski sign. If they are there, then it is definitely meningitis. And we have got a very high sensitive test, that is a jolt accentuation test. If it is not there, then it is very unlikely to be a meningitis. So even though these specificity sensitivity tests are going on, even with all the things being absent, the patient can still have the meningitis, especially when caused by a very rare or a very common enterobacteria species causing the viral meningitis. So this is also very, very common nowadays. So these can have a very low grade of inflammation in the meninges, where they may not have any signs of the meningismus at all. That's why the threshold becomes very, very important. The low threshold should be there. Why this is important? Because the way we give antibiotics for the meninges is completely different for the other infections. The antibiotics needs to reach the CSF, which is very, very, very difficult. So there are other symptoms which might suggest the etiological organisms. The one that is the rash, which is very, very important here, is the meningococcemia rash. So the rash is very prominent in these patients. They are principally located to the extremities. So this is also very, very important. These are not the centripetal rashes, these are centrifugal rashes. And here the rash initially to begin with is a maculopapular one, and it quickly evolves into the petechial phase. So this can be as quick as within 2 to 3 hours. You have gone to the patient in the morning rounds, the patient has meningitis and some amount of maculopapular rash. By the time you come for the evening rounds, the patient has developed a severe petechial rashes, which might actually frighten you to look to the patient. So this is very, very important, because this particular meningococcus, if at all it is detected, the prophylaxis needs to be given to the close contacts to prevent the development of further meningitis in the close contacts. One again very interesting and important thing is the presentation of this Listeria meningitis. Listeria has got a very huge tendency to cause the seizures in the early course of the illness, whereas other bacteria, they usually does not cause seizures. If at all they cause seizures, it is usually a very late kind of presentation, and focal deficits is also very, very early in the course of Listeria meningitis. So if at all in the clinical scenario, they give the history of the focal neurological deficits in the early course of illness, you need to suspect the Listeria meningitis in those patients. This is also important in the clinical practice also. And since they have got a tendency to involve the brainstem, it is also called the rhombencephalitis. So the most common organism or a bacteria which can cause rhombencephalitis is the Listeria meningitis. So especially the brainstem features like the cranial palsies, the nystagmus, and all these ataxia due to cerebellar or the tract enormment becomes very, very important in this Listeria meningitis. So the diagnosis of the acute bacterial meningitis is done through the CSF analysis. CSF analysis is must in all case of the acute bacterial meningitis, except in a patient who has got a very high raised intracranial tension. So this has to be detected by the getting the fundoscopy done before doing the CSF analysis in the patient. So there are some patients or some particular risk group where you need to get the CT scan before the lumbar puncture. Again, this is a very important question during the Viva OC of the PG or the during rounds. The examiner tends to ask this question very commonly. In an immunocompromised patient, you will get the CT before doing lumbar puncture. And in a history of central nervous system disease, like if the patient already had a mass lesion, now come with the bacterial meningitis, the patient had stroke earlier, patient had a focal, patient is suspecting to have a brain accident, new onset seizures. Like in the last 1 week of the presentation, along with the features of the bacterial meningitis, he had a seizure. First get CT, then get the CSF analysis. In the presence of papilledema in the fundoscopy, also needs the patient to take for the CT first. And the abnormal level of consciousness, especially the dipping consciousness, like if the patient's the GCS has been dropping suddenly, then you need to suspect the patient of another disease before going into CSF analysis. And again, a focal neurological deficit. If it is very promising, like the patient presenting with a typical hemiparesis along with the features of meningitis. You first get CT, then get CSF. But what is very, very important thing here is, if you are suspecting the bacterial meningitis, if you cannot do the lumbar puncture initially, before sending the patient for the CT scan, you need to give the first dose of antibiotic. There is no chance or no thing to delay the first antibiotic in these patients. The delaying of the antibiotic will definitely increase the mortality in these patients. So how do you come to the diagnosis in case of acute bacterial meningitis by CSF analysis? The first is the CSF pressure. The opening pressure is elevated in case of bacterial meningitis in all cases. The values of more than 600 millimeter of water suggest the presence of cerebral edema, the separation, or the hydrocephalus in the patient. The hydrocephalus is also very common with the Listeria monocytogenes. So the CSF pressure, make a habit of learning how to measure CSF pressure during your PG time. They got a CSF manometer during the performance of the lumbar puncture. You need to know how to measure the CSF pressure very commonly. This is also becomes very important in a patient who is suspected of having the normal pressure hydrocephalus. The very common disease in the old age, where usually people present with the urinary incontinence, the dementia, and the headache, along with the ataxia. So this is a very treatable cause of dementia, where patient present to you with a chronic memory loss. Where you diagnose the patient with NPH, if you remove some amount of the CSF, the patient is going to improve very rapidly here. And the CSF white blood cell count is important. The elevated cell count with a range of 100 up to till 10,000 can be very common in case of the acute bacterial meningitis. It is usually the neutrophilic predominant. Since it is an acute inflammation, the neutrophils are the soldiers here. So these becomes very predominantly infiltrated in the CSF. But some patients of the acute bacterial meningitis, the 10 or less than 10%, may have a lymphocytic predominance. So this is very common in case of neonates, especially with the gram-negative bacilli meningitis and the Listeria meningitis. So this is also an entrance question. The bacteria which can cause the lymphocytic predominance in acute bacterial meningitis is the Listeria meningitis. Again, CSF glucose is very low in case of acute bacterial meningitis because the bacteria depends on the glucose for their metabolism and for their energy. So they consume the glucose from the CSF. So the CSF glucose gets reduced. So usually the absolute value is less than 40 milligram per deciliter. Whereas in other causes of the chronic meningitis, like viral encephalitis or viral meningoencephalitis, the tuberculosis, the glucose can be normal. So very important thing here is to take the simultaneous sample to measure the serum glucose. Because the sugar to be reduced in the CSF, the absolute reduction should be less than 60%, or you can also calculate the CSF to serum glucose. It should be less than 0.7. Some textbook also mentions 0.5. So this is been observed in 70% of patients because, for example, if the patient is having a diabetes and he is having an uncontrolled diabetes, so he comes to the feature of acute bacterial meningitis, you measure his blood sugar, his CSF sugar comes 100. And this, if you take an absolute value, you can consider the CSF glucose as actually normal. Whereas if you see his serum glucose, it can be more than 600. So for this amount of serum glucose, this amount of CSF glucose is actually considered as very low. So you need to remember the percentage of reduction of the CSF glucose to be considered as significant. This is also very important. And CSF protein gets elevated in virtually all cases. Sometimes it may go above 500 milligrams in some patients. And the very important in etiological diagnosis is the CSF gram stain. And this can be done in the bedside. This has been very commonly done by the pediatricians, but they have a habit of keeping the specimen and the microscopy in the emergency ward itself. Although the medicine wards don't have usually these kind of facilities, but it is better for the medicine graduates also to learn how to do the gram stain and rapidly identify the organism, which actually narrows down the treatment in your case. So this is also becomes important because if you send a gram stain to the microbiology lab now, sometimes they may give a report after one day by the time they come and stain, the organisms might have actually degenerated and all these things can happen. So it is better to do the gram staining in the bedside to have a very good specificity. So the likelihood of organism is greater if the high bacterial densities. This is also very, very important here. And CSF culture can be positive in case of the 80 to 90% of patients with the community acquired bacterial meningitis. Again, if the patient has taken an antibiotic dose prior to the coming to the hospital, the yield can be very low. And this CSF lactate has become a interesting thing nowadays to differentiate between the bacterial meningitis and the viral meningitis, which has got both high sensitivity and specificity in differentiating between the bacterial and aseptic or viral meningitis. So sometimes the rapid diagnostic tests are also available, but they are usually not recommended in the routine practice. We have got a latest agglutination test available for all these organisms which can detect H. influenza B, the streptococcal pneumoniae. All these can be done, but they are actually not routinely recommended by the IDSA or the ICMR. PCR can be done nowadays. We have got a rapid multiplex PCR. If you give a CSF sample to the lab, they test the multiple organisms simultaneously, where the reports can be attained as early as 2 to 3 hours, where they can test, I think, more than 10 bacteria and more than 20 viruses together in identifying the organisms. So this has also become a routine practice nowadays. So what is the initial approach in the management? I think one very important thing is there is no scope for delay. There should not be any delay when you suspect acute bacterial meningitis. If acute bacterial meningitis comes to you in your mind, first thing you do is giving the antibiotic for the patient. So if you got a suspicion for the bacterial meningitis, if these factors are not there, like patient is not immunocompromised, there is no history of CNS disease, there is no new onset seizure, there is no papilledema, straight away first send the blood culture, take the lumbar puncture, and give the antibiotic along with the adjunctive therapy, that is the dexamethasone. There is a star mark, which we'll discuss later. So this is very, very important here. Yes, if you decide to get the patient the CT, before sending the CT, take the patient blood cultures, give the antibiotic, then perform CT scan. This is also very, very important. This is because I have seen many emergency PGs sending first patient for the CT before even touching the patient. That is been a very, very wrong. First, check for the nuchal rigidity. If the patient has nuchal rigidity, then it's well and good. Then check jolt accentuation. If the patient has jolt accentuation, then check for the fundus. If there is papilledema, if these factors are not there, straight away do the CSF right away and give the antibiotic. Then discuss further issues. If they have got anything before sending into the surgery, take the blood cultures, give the antibiotic. Then after confirming that there is no raised ICT, patient can be go ahead with the lumbar puncture. Then you can go for the lumbar puncture. If there is contraindication for the lumbar puncture, if the patient has got a pretty high raised ICT, then you can continue the medical therapy for the bacterial meningitis, or you can also consider for the alternative diagnosis, like the patient can have the lung abscess, patient can have other features also. So if you have done the CSF, these features are consistent with the CSF meningitis, and try to identify the organism in the gram stain. If you have got positive gram stain, the identification is possible, then you can consider the targeted antibiotic therapy. If there is no gram stain yield, then you can consider the empirical therapy, and treatment can be later modified based on the patient's improvement. So this is a very, very important thing here to which antibiotic should be considered in the management of the acute bacterial meningitis. So deciding the empirical therapy, the age becomes very, very important. So for the physicians, these two groups are very, very important. The 2 to 50 years, that is maximum number of patients, except old age patient, all the middle age patients, we know the two organisms we are dealing with are the most common. So the drug of choice becomes the third generation cephalosporins plus vancomycin. So my question for all the viewers here is why vancomycin is being included in the empirical therapy of the acute bacterial meningitis. Although both streptococcal pneumonia and Neisseria meningitis inherently are susceptible to the penicillin group or the third generation cephalosporin, why the vancomycin is included. And if the patient is very old age people, the Listeria monocytogenes comes into the picture. So the addition of ampicillin becomes very, very important in the management. So I have given the IDSA guidelines and the ICMR guidelines both. There is no much difference in the management in the both sections. Both the ICMR and the IDSA consider the vancomycin with the third generation cephalosporin as the drug of choice. Although ICMR give the specific indication of the ceftriaxone, the IDSA can give the IDSA is usually giving the two options. One is either ceftriaxone or you can consider the cefotaxime, the taxime or the zone. So these are the options given by the IDSA, whereas the ICMR gives the ceftriaxone as the direct antibiotic for the management of the acute bacterial meningitis. The recently NIMBR fourth generation cephalosporin, the cefepime, has also been considered for the addition along with the vancomycin for the management of meningitis according to the IDSA, but still the ICMR considers the ceftriaxone plus vancomycin as the treatment of choice in case of meningitis, and ampicillin you need to add in a patient who is having a risk factor for the development of the Listeria monocytogenes. So this is a very, very important thing here. Then if the patient, what to do if the patient is having the immunocompromised state? For example, if the patient is having an HIV, if the patient has undergone the organ transplantation on immunosuppressed therapy, patient on chronic glucocorticoid therapy coming to you with meningitis. So again, you need to follow the guidelines as per the age 50-year-old. The Listeria monocytogenes is very common in the humoral immune-mediated dysfunction. So you need to add ampicillin in these patients. So ampicillin is added in three varieties. One is either if the patient is neonate, if the patient is very old age, or if the patient is immunocompromised. So this is also the entrance question which was asked related to the Listeria monocytogenes. I think they gave one odd option. So these three options were the right options in those patients. So in post-neurosurgery patient, the Staph aureus and cons, as I told you, the skin inhabitants becomes the very, very common organisms. So you need to consider either the cefepime, which is a fourth generation cephalosporin, which along with the coverage of the gram-positive cocci has also got a very good action against the Staph aureus, preferably MRSA. So this can be considered as the choice. And ceftazidime, because since it is a hospital-acquired infection, so the gram-negative bacilli like the E. coli, the pneumococcus, the Pseudomonas becomes very, very important. That's why the ceftazidime and meropenem came into the picture. Again, if the patient has got a bacillar skull fracture, as I told you, the Staph aureus is a very common organism. The trauma patient need not change the regimen, that is the third generation cephalosporin with vancomycin becomes the choice. If the patient has a penetrating trauma into the brain, so then again, since it is a neurosurgery, intervention might be required. And since there is an introduction of the foreign body into the brain parenchyma, the coverage with the Pseudomonas or the gram-negative bacilli and the Staph aureus becomes very, very important here. But irrespective of all the things, the third generation cephalosporin plus the vancomycin is the treatment of choice for the empirical therapy of all kinds of majority of bacterial meningitis. And ampicillin in three categories, that is neonate, the age 50, and immunocompromised patients. This is also very, very important. So if you see the penicillin group of antibiotics, that is the cephalosporin, is the bread and butter of this acute bacterial meningitis. So what to do if the patient has the beta-lactam allergy? So then it becomes a very interesting issue. So this beta-lactam allergy can be IgE mediated or it can be non-IgE mediated. As I told you in the last class also, in the case of pneumonia, how to identify whether it is a non-IgE mediated or IgE mediated. IgE mediated are usually reactions caused by the mast cell degranulation, that is the anaphylaxis or the angioedema, urticaria, and all these things. So this non IgE-mediated reactions are the usually maculopapular rashes, simple maculopapular rashes. So if the patient has a history of this non-IgE mediated reactions, like patient might tell you, sometimes when I was a child, I was given this white color injection, I had developed some amount of rash. So that is a non-IgE mediated thing, where you can still consider the cephalosporin as a treatment, because the cephalosporin particular allergy is also very, very less in the patient. Whereas if the patient gives history of the IgE mediated reactions to the penicillin group of antibiotics, and if the patient has a history of the third generation cephalosporin susceptibility, like sometimes I was given cefixime or cefuroxime or cefodoxime, I did not have any reaction, then you can definitely go for the cephalosporin. If the patient also had a reaction to the third generation cephalosporin, then you are given the options along with the vancomycin. You can go for the meropenem, you can go for the moxifloxacin, or you can go for the aztreonam. The aztreonam was specifically considered when you are suspecting the Pseudomonas. The moxifloxacin can be considered when you are suspecting the gram-negative bacilli, and meropenem can be considered for all the organisms, and spectrum is very, very long. And moxifloxacin is the one fluoroquinolone which has got a very highest CSF penetration among all the fluoroquinolones. That's why moxifloxacin becomes the thing here. So otherwise, all these things are routinely not included in the management. But the beta-lactam allergy, especially the severe allergic reaction to both penicillin and the cephalosporins, makes the diagnosis, or sorry, the treatment towards either meropenem, moxifloxacin, or aztreonam in our patients. So the dose of the meningitic dose of these antibiotics is also very, very important. The very commonly used antibiotics, that is zone and the taxine. So this is very, very important. This is 2 gram 12 hourly, that is double of the normal dose is used. Why? This is because normally CSF is non-penetrable by penicillin group of antibiotics. That is, normally in normal patients, the ceftriaxone and cefotaxime cannot penetrate the CSF. Whereas in presence of meningitis, there is an alteration of the blood-brain barrier due to the separation of these tight junctions, due to increased vascular permeability in the meninges. So they become the penetrable into the CSF. And since these are the cephalosporins, these have got the concentration dependent action in the body. So their bactericidal effect depends on the time above which the mean inhibitory concentration is achieved in the body. So that's why these are given as a high dose for frequent duration. This is also very, very important in patients. Cefotaxime is given every 4 to 6 hourly. That is, can be given 4 times 2 gram dose. Ceftazidime, again, as I told you, can be considered in a Pseudomonas thing, but routinely the ceftazidime is not a good antibiotic for the management of the acute bacterial meningitis. If at all you have got a ceftriaxone, cefotaxime is available. If it is not available, then you can have a consideration to add the ceftazidime, because ceftazidime has got an inherent less activity against this pneumococcus, which is the most common organism causing the bacterial meningitis. And cefepime, as I told you, the 4th generation is good. So it is 2 gram TID. And ampicillin, please remember, it is 2 gram 4 hourly. And one important thing we should remember is the vancomycin. So vancomycin given is the 50 to 20 mg per kg every 8 to 12 hourly. This is the similar dose given for the paracetamol. You can remember. So this is both 50 to 20 mg per kg given every 8 to 12 hourly. And if you have got a proven MRSA in your patient, then the vancomycin regimen becomes different. Where you have got a very high loading dose to be given to the patient, like 25 to 30 mg per kg. Then the maintenance dose of 15 to 20 mg can be given for the 8 to 12 every 8 to 12 hourly. And meropenem is given 2 gram every 8th hourly. So the double dose, normal dose is used routinely. So you should not use the routine doses. The meningitic doses are specific. So if you are suspecting the meningitis, give the 2 gram shot of ceftriaxone, which reduces the mortality by 30% in your patient. The first dose of antibiotic in any patient of infection, especially in 2 patients, that is, one is sepsis and another one is bacterial meningitis, becomes very, very important and very important life-saving things. And there is no scope for any oral antibiotics in a patient of meningitis. there is only one oral antibiotic which can be given in a patient of the acute bacterial meningitis. Again, this is a question for all you guys. I will wait in my chat box. Which is the only oral antibiotic that can be used in acute bacterial meningitis. So what is the adjunctive therapy? The adjunctive therapy is the steroid, that is dexamethasone. So this is a controversial discussion, but as of now, we have got a clear guidelines in the management. Whenever you are suspecting the patient with the antibacterial meningitis and you don't have any etiological diagnosis right away, like majority of the patient in the wards, like patient comes to you with the bacterial meningitis, the gram stain becomes very difficult, and after the lumbar puncture, you need to give the antibiotic. Every patient of acute bacterial meningitis to be given a shot of steroid plus an antibiotic. So ideally, this shot of steroid should be given 4 to 6 hours prior to the first antibiotic. Ideally, but if it is not possible, then it should be ideally given at least along with the antibiotic. Like there is 10 to 20 minutes of gap can be given. But if you're already given an antibiotic, but there is no scope for the adjunctive dexamethasone therapy. This is a very important thing. If the patient has transferred from one hospital to another hospital, if they've already given the meningitic dose of the first antibiotic, then the dose of dexamethasone need not be given, as it does not give any benefit to the patient. So what are the benefits of giving IV dexamethasone? One is decrease in mortality. So this is shown to decrease the mortality, especially in the developed countries. Although in developing countries, there are no clear-cut trials regarding the use of the dexamethasone, but in developed countries, the pneumococcus is the very common organism, and the mortality was shown to reduce by giving the dexamethasone. And the next is the reduction in the neurological complications. And the third one is the reduction in the incidence of the sensory neural hearing loss. So there was an entrance question asked, I think in 2019. So what was the benefit of giving dexamethasone? The options were it reduces mortality, it reduces the neurological complication, it reduces the sensory neural hearing loss, it reduces the incidence of blindness. So it does not reduce the incidence of blindness. It reduces 3 complications. One is the mortality is directly reduced, and the neurological complications are reduced, and the incidence of sensory neural hearing loss, which is very common in a patient of pneumococcal meningitis, is also been reduced by giving an adjunctive dexamethasone therapy. So ICMR gives these lines. The administration the 15 to 20 minutes prior to the first dose of antibiotic has been found beneficial for the pneumococcal meningitis in adults and the Haemophilus influenza meningitis in children. And the ICMR gives this statement that is benefit is doubtful in childhood pneumococcal meningitis, because whatever the studies done in the developing countries were done for the adults. So the benefit is doubtful in childhood, but it can be considered in the children, but it is not recommended in the neonates. So the neonates need not be considered for the adjunctive therapy. And the dose of the dexamethasone is also very important. It is the 0.15 mg per kg every 6 hourly for 2 to 4 days after starting the antibiotic. So it ideally comes around the 10 mg for every 6 hourly in adults. So this is very important. And the 3 things which you should remember that dexamethasone reduces is the mortality, the neurological complications, and the sensory neural hearing loss. So if the ideal treatment, the majority of the patients are going to improve. If you need to consider the repeat analysis of the CSF, then there are some indications. One is the clinical non-response at the 48 hours. If the patient is behaving same even after the starting antibiotics, you need to consider the repeat CSF analysis. And patients with the cephalosporin resistant strains who have received the adjunctive dexamethasone. This is because there is a questionable issue regarding the addition of dexamethasone when you are giving vancomycin. Like some studies have told that dexamethasone actually reduces the vancomycin penetration into the CSF. So I had asked you the question why we are using vancomycin in a patient, and both pneumococcus and meningococcus are susceptible to the third generation cephalosporin. This is because I think in 2009 there came a guidelines by the IDSA where they mentioned anywhere area which has got the pneumococcal penicillin resistance of more than 1% should be considered the addition of vancomycin in the management. So vancomycin is a good drug for the pneumococcus if they are penicillin resistant or the cephalosporin resistant. That's why we don't want to take the chance of the pneumococcal resistance in these patients. So along with the third generation cephalosporin, we are adding the vancomycin in all the patients who are suspected of the bacterial meningitis to miss a chance. So what the IDSA gave guidelines was more than 1%. So if you take in India, hardly there are studies regarding the pneumococcal resistance in India. So, but the one large study was done in the CMC Vellore, where in 2008, the penicillin resistance was 8% in pneumococcus, whereas by the 2018 year, the resistance grew by 45%. Among this, 20% were actually resistant to the cephalosporins directly. So, since the resistance of the pneumococcus is very, very high in India, we also add the vancomycin in our patient. And in neonates, it is very important to document the sterilization of CSF. So in all neonates, we should consider the repeat CSF analysis because it tends to have an effect on their upcoming neurological development. So you need to develop the complete sterilization of CSF. Whereas in adults, we don't need to demonstrate the sterilization of CSF routinely. There are some complications of the meningitis routinely. Although this is very rare, this has been reduced with the right antibiotics and the adjunctive therapy, but this can happen. The patient can have a subdural empyema, the patient can have a subcerebral abscess, the ventriculitis can develop, and drug resistance is also a complication of any infection nowadays. So what is the duration of therapy? Any uncomplicated meningitis, 10 to 14 days, that is the 2 weeks antibiotic should be given to the patient. This is also very, very important. Sometimes there is a habit of discharging early due to some financial constraints or some bed availability. The patient tends to get discharged early, but in the case of meningitis, you need to give at least for the 10 to 14 days duration the right antibiotic. The meningococcus and the H. influenzae can be considered for the lower duration of therapy, that is 7 days. The longest treatment duration is for the listeria, that is 1 to 1.5 months might be required for the listeria. So let's take some questions here. The 19-year-old man who presents asking for advice. His girlfriend has recently been diagnosed with the meningococcal meningitis. He is worried he may have caught it. So what is the recommended antibiotic prophylaxis for close contacts such as this man? So the recommended antibiotic is the oral rifampin, or the other options are the ciprofloxacin. These are the first line of therapy. Where the alternative therapy is the azithromycin. But the drug of choice is always the rifampicin or the rifampin for the prevention of the meningococcal meningitis in close contacts. So for the prevention of the meningococcal infection, I think you might have surely experienced in your ward whenever you have got a case of meningococcal meningitis, that rash is definitely unforgettable, and everybody in the ward is giving receiving the prophylaxis. All the patients you are giving ciprofloxacin, or all the patients you are giving rifampicin, you yourself taking ciprofloxacin. This becomes very, very common. So how to prevent this? One is the droplet precaution. Like you need to keep the patient in isolated ward by preventing droplet. So since the meningococcal is spread through the droplet infection, and then antimicrobial prophylaxis need to be considered for the close contacts. Who are the close contacts? The close contacts are those who are exposed with more than 8 hours per day and with a less than 3 feet duration, like all the related ward boys, the cleaning guys, the household contacts, and the PGs who have done some intervention, like somebody has intubated the poor patient. So this becomes a very, very important close context. So what is timing prophylaxis? It should be given within 24 hours. More than 24 hours delay will increase the chance of having a meningitis in that close contact. So the within 24 hours of the exposure, you need to consider for the prophylaxis. The preferred regimens are the rifampicin or the ciprofloxacin or the ceftriaxone. If they ask the drug of choice, it is the rifampicin. An alternative is the azithromycin. So to take the next question here, there's a 21-year-old college student with no significant past history comes to the student health clinic reporting 1 to 2 days of malaise and 12 hours of worsening headache, fever, mild neck stiffness. He is a varsity swimmer. He takes no medications. He is heterosexually active and has had an unprotected intercourse with 4 different partners in the last 6 months. His examination is notable for BP of 110/60, heart rate of 105, respiratory rate of 20, temperature of 103. His mental status examination is entirely normal. This is very, very important. And there is a pain on the neck movement. But his neurological and fundoscopic examinations are unremarkable with no focal findings. Based on these findings, which of the following is the most likely diagnosis? So this is a simple question, but it is a lengthy question. To answer this question, you need to know what is meningitis, what is encephalitis. So meningitis is an inflammation of the brain meninges. Encephalitis is the inflammation of the brain parenchyma. How will you differentiate between these two? Meningitis patient tends to have the features which are suggestive of fever and the features of meningitis, that is headache, the photophobia, and the neck stiffness. So this is a meningitis. Whereas features of encephalitis are the symptoms pertaining to the involvement of the brain parenchyma. The patient can have a seizure, an altered sensorium, abnormal behavior. These are the features of encephalitis. So this becomes very, very important here. And what do you mean by cerebritis? Cerebritis is a focal infection, whereas encephalitis is a diffuse parenchymal infection. Cerebritis is a focal infection which does not have a capsule. So these patients present to you with a feature of the focal neurological deficit, like patient can have a right-sided hemiparesis in the right-sided frontal or temporal cerebritis. All these can be common. When this focal infection gets the developed capsule, then it becomes the brain abscess. So these definitions, which are simple, but needs to be remembered very properly during the examination. Again, as I told you, these questions are actually very simple when you directly solve the questions regarding that particular system. For example, you are studying the CNS infections, you have studied the CNS infection, now you are solving the questions. This may actually seem very easy. But when they come in the midst of an exam, with all the systems which are included in your mind, so these simple questions will also become complicated. So these are the questions which tends to carry very high marks in the relative grading. So this is not a case of an acute disseminated encephalomyelitis because there are no features of an encephalitis or myelitis in this patient. Encephalopathy, there is no feature of an altered sensorium in this patient. There is just a fever, there is a headache and mild neck stiffness. So encephalopathy cannot be there. So mass lesion. So mass lesion needs to have a very severe headache and patient usually have either a seizure or a focal neurological deficit. Then meningoencephalitis. Encephalitis, again, as I told you, patient needs to have either seizure or the abnormal sensorium or the abnormal behavior, which is not there. So the last option we are left with is the viral meningitis. So this patient has a simple acute viral meningitis. This patient who has just headache, which is worsening, an acute fever and mild leg stiffness. So this is an important question here. All of the following are the predisposing conditions that increase the risk for the development of an acute bacterial meningitis due to streptococcal pneumonia, except. So they're just asking which is not a risk factor for developing streptococcal pneumonia. Alcoholism is a risk factor. Any pneumococcal infection in the body, pneumococcal pneumonia, sinusitis, otitis media, all these are the risk factors. And again, splenectomy is a risk factor for the capsulated organism. Pregnancy is not a specific risk factor for the streptococcal pneumoniae, whereas it is a specific risk factor for the Listeria monocytogenes. So in future, the question might come, which has got the maximum risk among these? This is the pneumococcal pneumonia. So the maximum risk of having the meningitis by the pneumococcal organism is in a patient of pneumococcal pneumonia. If a patient has got a pneumococcal pneumonia, there's a very high chance of developing pneumonia meningitis in this patient also. And one very important question you should also remember is when you should vaccinate in a patient who is planned for splenectomy. Within 7 days of planned splenectomy, the first shot of a vaccine for the streptococcal pneumonia should be given within 7 days of the planned splenectomy. This is also an entrance question. So to take the next question here, there is a 28-year-old army recruit who is brought to the local hospital with 12 hours of worsening headache, mild confusion. She has no significant past medical history, takes no medication, does not use cigarettes, alcohol, illicit drugs, and is not recently sexually active. For the past 2 days, she has had a low-grade fever, malaise, dyspnea on exertion, and a productive cough. Her vital signs are as follows. The BP was low, the heart rate is high, the respiratory rate is high, saturation is low, and temperature is 104 degrees Fahrenheit. She is oriented to person and place, but she thinks the year is 1999. That is, she is not oriented to the time. The Kernig's and Brudzinski signs are positive, but the remainder of a neurological examination shows no focal findings. If they are positive, since they are very specific, we need not have any other suspicion. The patient is definitely have a meningitis. The chest examination reveals a bronchial breath sounds at the right base. Her abdomen and skin examinations are normal. The portable chest radiograph demonstrates a small right lower lobe infiltrate. So the patient has the right lower lobe pneumonia plus acute meningitis. So here what they are asking is, all of the following medications should be used or administered immediately except. So dexamethasone should be administered, the ceftriaxone should be administered, the vancomycin should be administered. Now coming to you, the confusion between the acyclovir and the ampicillin in this patient. So ampicillin is not indicated because the patient is definitely not a case of the Listeria monocytogenes risk age group. That is, patient is not neonate, patient is not a old age, patient is not pregnant. So ampicillin is not routinely used. Acyclovir is used for viral meningitis. So all of the following medication should be administered exceptly. So we have the two confusions here. So acyclovir can be the option, ampicillin can be the option. So if you ask me which is the right option, then it is the ampicillin. Because at this particular time, we don't have the CSF picture. We know that this is a meningitis, but it still can be the viral meningitis, which is a very, very common in a patient of this age group. So that's why the acyclovir can be given in this patient, but ampicillin does not have any evidence. Only in a patient of neonate and the patient of the old age group and pregnancy should be considered for the addition of ampicillin. Otherwise, there is no scope for ampicillin at all. So the ampicillin is the right choice here. So some short discussion on the intracranial suppuration, that is a brain abscess. The brain abscess begins as a localized area of cerebritis. As I told you, if this cerebritis develops a capsule, then it becomes a brain abscess. It has got a very low incidence nowadays, less than 1%. And it is usually the most commonly spread from the contiguous septic foci, usually the ENT cause. Like patient can have a otitis media, the sinusitis, patient can have the mastocytitis, very, very common. Hematogenous source from the distant foci is the next most common, especially the endocarditis patients. Direct trauma, neurological procedures are also very, very common. Cryptogenic, that means the idiopathic, which cause cannot be identified in 20% of patients. So if you see the spread from the contiguous focus, the most common cause is the ENT infection, that is the otitis media and mastocytitis. This is also an entrance question. And what is the most common site of the development of the brain abscess in the ENT caused brain abscess is the temporal lobe. Next most common is the cerebellum. Whereas the dental infections, the most common site of the brain abscess development is the frontal lobe. Sometimes a meningitis can become a lung abscess, very rarely. It can happen in neonates with some infection that is called a Citrobacter diversus meningitis. This, I don't know whether this has been asked till now or not, but this can be the question, which bacterial meningitis can get converted into the brain abscess, that is the Citrobacter diversus meningitis in the neonates. Then it can be from the hematogenous spread, like especially the lung source, that is the patient have a suppurative lung lesion of empyema, lung abscess, bronchiectasis, very common, and some wound infections, intra-abdominal infections are also very common. Then the trauma, direct trauma of the penetrating trauma, gunshot wounds are very common. And neurologic surgical procedures are also very important. And cryptogenic needs to be suspected in patient of asymptomatic pulmonary venous malformation or a cyanotic congenital heart disease in the background. Then the most common organism causing the brain abscess are the streptococci, that is the Streptococcus intermedius, including Streptococcal anginosus. Next is the bacteroids, that is the Pravotella species, which are the natural inhabitants of the oral cavity. Next comes the Enterobacteriaceae. The Staphylococcus aureus comes somewhere in the middle. So it is the streptococci, that is the group A streptococci, are the most common cause of the brain abscesses. And the usual features are the headache, fever, and altered mental status, and the seizures, nuchal rigidity, and the focal neurological deficits can be common. So less than 50% of the patients are actually having the triad. Prominent symptoms are due to the mass, not to the infection. Although patient might look toxic in your clinical history, but patient presents majority with the symptoms pertaining to the mass effect, like focal neurological deficit. And overall, most common symptom is the headache. And as many as 50% of patients, the fever may be absent. This is very important. This is one cause where there is a pus in the body and incidence of fever is as low as less than 50%. Whereas any pus in the body will definitely manifest with a very high grade fever, except for the brain abscess, which can manifest with fever as being less as 30–50%. And symptoms pertaining to the location might vary, like a patient of occipital brain abscess may have a blindness, patient of the frontal lobe may have a behavioral abnormalities like this. And the lumbar puncture is contraindicated. In the suspected lumbar puncture, the investigation of choice is the MRI brain. Don't go for the lumbar puncture in case of suppurative brain lesion. If they ask what is the investigation of choice in suppurative brain lesion, sometimes they give questions like this. So the investigation of choice is the MRI brain. So if you do the laboratory test, it may suggest some amount of leukocytosis, where it can be normal in some patients. There is rise in ESR due to pus in the body, and chest X-ray may be useful if there is a spread from the hematogenous focus. And sometimes EEG may localize to the site of the lesion. And CT scan and MRI are very important. The CT scan is very important in especially identifying the ENT causes like the middle anatomy, sinuses, mastoids are very well located in the CT scan. Whereas for the diagnosis, a very sensitive investigation of choice is the MRI brain, because in CT there are a lot of differential diagnosis for the brain abscess. So if you see this brain abscess in CT, this actually looks as a hypodense center with a variably hyperdense ring enhancement. So this is usually uniform, that is a uniform length around the circumference. And there is some amount of the hypodense area surrounding the lesion, that is the surrounding edema. This is how you diagnose the brain abscess on the CT. So you can see the location here, the temporal lobe, just pertaining to the secondary to mastoiditis. So here, if you can directly see the mastoid hair cells, here they are obliterated due to the presence of infection. So in MRI, in T1 weighted images, it is similar to the CT, where the center appears as hypointense with a very hyperintense capsule. If you get a T2 images, the pus is very bright in T2. As the capsule become hypointense, you can see this. And again surrounding this, there is a hyperintense brain edema. And again surrounding the hyperintense brain edema, there is another hypointense area, that is capsule. So this is called as double rim sign. is a very, very important thing, which are usually not seen in other ring enhancing lesions like gliomas, toxoplasmosis, all these things. So you should know some basic knowledge regarding the MRI, the identification of this. In CT, the center is hypodense and there is a surrounding ring enhancement in a contrast-based image. In T1, it is just similar to CT, where the center is hypointense, whereas intensity is the word which we use for MRI description, whereas density is the word we use for CT. Since it is in MRI, the center is hypointense, whereas we have got a capsular hyperintensity. In T2 weighted images, the pus becomes very bright. That means center becomes very hyperintense. The center becomes very hyperintense. Then the surrounding hypointensity due to capsule. Then there is a surrounding variable edema, which also becomes hyperintensity. So this may cause the double rim sign in T2 weighted images. Sometimes it becomes very difficult when there is a necrosis in the malignancy, because since pus is also necrosis, this might create confusion. Whereas to differentiate between the glioma, you can get the diffusion weighted images where the pus is diffusion restricted. You can see the pus, which is very bright in here, diffusion weighted images, it is restricting the diffusion. So the surgical management is a treatment of choice for the lung abscess. There are two kinds of procedures available. One, you can aspirate and you can excise directly. In aspiration, there is less tissue damage, whereas in excision, there is a more tissue damage. Aspiration can be done stereotactically if it is deep-seated. Since it is an interventional procedure, there is a risk of hemorrhage. It is done in early stages of cerebritis where there is increased vascularity, and it can be considered for the very small lesions or very deep-seated lesions. Whereas if the abscess is very large, it is better to consider for the excision. So medical management, although medical management is not a main thing to do here, it can be considered when the abscess is very small in the early stage, or when the abscess is in such a location where it is inaccessible to the neurosurgical procedure. The antibiotics of choice are the either Taxim, the ceftazidime, ceftriaxone, third generation cephalosporins, with the metronidazole and vancomycin being the choice here. Then steroids in the brain abscess are controversial. They should be restricted in only some patients where there is a progressive neurological deterioration, there is impending cerebral herniation. For example, take this patient, there is a gross midline shift in this patient. See this. See the midline shift. So this patient can be considered for the steroids in the early course. And if the radiological evidence causing significant perilesional edema and mass effect, again see the perilesional edema, which is very significant, which is actually pushing the parenchyma towards the opposite side, which is impending uncal herniation. So the steroids are very quick in reducing the focal edema. So sometimes the use may be harmful, especially they can cause the delay in entry of the antibiotics into the CNS, and they impair the clearance of the antibiotic from the body, and they inhibit the capsule formation, and they alter the appearance of the follow-up radiological imaging. That's why you need to assess the risk-benefit ratio in giving the steroids in a patient of brain abscess. In the early stage, you can consider if there is a impending herniation, you can consider, and significant brain edema, you can consider. The subdural empyema is the most common sinusitis-associated intracranial infection. Again, this is an entrance question. See, you can see the frontal sinusitis here, and you can see the empyema, the subdural here. So frontal sinus is the most frequently implicated and most common location of the subdural empyema is the frontal lobe. This is also a question. So other sources are being from the meningitis, the otitis media, head trauma, and other. And most often it is monomicrobial. And organisms found in the paranasal sinuses usually do not correlate with the subdural cultures. So they may grow completely different organisms altogether at the same particular point of time. So this is interesting regarding this. So the most common organisms are the aerobic and the anaerobic streptococci. And some due to lack of anatomical constraints to limit the spread of infection in the subdural space, the clinical manifestation can progress very rapidly. So this infection can spread very rapidly because of anatomical constraints. Whereas in the case of lung abscess, since it's a very capsulated thing, the symptoms are limited to very one particular site. So again, the treatment of choice is the surgical intervention here. You can either go for a burr hole drainage like the subdural hemorrhage, and you can also go for craniotomy drainage. Then you need to consider for the exploration of sinuses to relieve the chronic sinusitis in this patient and consider for the empirical antibiotics. And the CSF shunt infections are also very, very important, especially in the case of the neurosurgical procedures, where patients tend to get implanted with the shunts permanently or temporarily, especially the ventriculoperitoneal shunts. So here the most common organisms are the coagulase negative staphylococci and the Staph aureus. The symptoms are similar to the meningitis. Along with the symptoms of the meningitis, you have got symptoms of tracts related symptoms, like if the patient has created a subcutaneous ventriculoperitoneal shunt, the shunt runs in subcutaneous cavity, then along the shunt there may be development of an erythema, or there can be sometimes a distant symptom that is specifically called as shunt nephritis. The one form of an acute glomerulonephritis, which is immune complex mediated due to presence of shunt and shunt related infection in the body, where the patient presents with the proteinuria, hematuria, and glomerulonephritis. So, but the treatment of CSF shunt infection is similar to the meningitis, where you need to consider third generation cephalosporin and the vancomycin, and you need to, along with the CSF culture, you need to get the culture of this shunt or the shunt cavity for identification of the organism. So I think we will end in this class here. In the next class, we will consider some of the viral encephalitis and the tubercular meningitis and some interesting and important CNS infections. Thank you.
Thank you so much, sir. It was indeed a very comprehensive class and we learned a lot. And thank you so much for taking this series of classes like this, and which is very helpful for us. And we have got so many feedbacks, positive feedbacks for this session, sir. Thank you so much, sir.
Thank you.